So we've learned that the cervical spine, that there are 7 vertebrae. We know that there should be only 7. Thoracic, there's 12. Lumbar, there are 5 vertebrae. It would be considered a secondary curvature because of the direction of the curve. Primaries would be of the thoracic and sacrum. Relate that to the fetal position is an easiest way to remember it. But these are in our lower back, and because of the curvature, because of the structure of our axoskeletal system, the lumbar spine tends to take a lot of the weight. And for most Americans, a lot of the weight is being pulled forward because we tend to be overweight, which tends to accentuate the curve, or there might be a slippage of the disc. One of the greatest medical professionals are susceptible to lower back pain because of the amount of lifting that we do. Something to be very cognizant of when we do the patient care transfers, etc. But you always want to be conscientious that you only have one lower back that consists of the 5 lumbar vertebrae. So there are 5 in number. They occupy the posterior abdomen. Some of the unique features of it: transverse processes are smaller than the T-spine transverse process, and that is due to the facets for the rib, the demifacets, etc. And here's a new word that we're going to bring up: pars interarticularis. It is an important word to remember and know when it comes to knowing the Scotty dog. So the pars is part of the lamina between the articular processes of the transverse and spinous process. So it would be coronal posterior or coronal plane, transverse process, going backwards to the spinous process. In between, in that region where the lamina lies, it is just in that region. So looking at it in 2 different views, once again, you can see that we have a very large body. Posterior to the body, on either side, would be the pedicle. Transverse processes on either side. Here's our lamina, and the pars, well, I'll show you on the next one, really lies in this region here on this lateral. From the lamina, we have our spinous process, and once again, the superior articular process and the canal by which the spinal cord goes down through. On the lateral, you will notice that the spinous process, once again, is a little more rounded compared to the thoracic. It's a dead giveaway. And remember, cervical spinous processes tend to have a bifid tip. The body is a lot heavier and thicker. Then we have the inferior vertebral notch and superior vertebral notch, which, when combined with the vertebrae above and below, meet together and are the intervertebral foraminas. So, first of all, orient yourself. The picture on your right is an oblique of the lumbar, looking off towards the right side, way over here. And this image of one vertebrae is looking off to the left, so they're opposites. So try to orient yourself. So we have our body up front, transverse process, superior facet. Behind the transverse process, just inferior to the facet, would be the pars interarticularis. And then posterior to that would be in the region of the lamina. From here, this would be the spinous process. Inferior articular facet or process here, or superiors are here. Looking at it in a different view of the whole spine in the opposite direction, we can see the ZAs from the inferior and superior articular facets, posterior to the transverse process, which I don't even see here. Oh, here's the transverse process. Posterior to that region would be in the pars interarticularis region. Okay? It's a word that you need to know. Is that a blatant hint or what? Okay.
So is it superior to the lamina?
It, I would say it's slightly superior and anterior. Yeah. So lamina would be posterior. So it is a little bit more superior and anterior. Now, this is where all the numbers and angles that we have talked about throughout the semester really matter. We talked about the degree at which we need to rotate for the cervical and looking at the intervertebral foraminas. That when we took the mid-sagittal plane and the coronal plane, that it would be off about 45 degrees. The thoracic spine was different. It was off 20 or 70, depending on which way you're rotating the patient, from a lateral or from a supine AP. For a lumbar, the range is anywhere between 30 and 60 degrees that the ZA would lie. This has to do with the size and shape of patients today and how the curvature of the spine tends to go from posterior to anterior back to posterior, and how the vertebrae line up with one another. Normally in L5, S1 region, we tend to have to rotate the patient more to be able to look at the zygapophyseal joint. For our positioning, everyone here knows that we rotate the patient 45 degrees, correct? It is known, 45 degrees. But when you really evaluate the Scotty dogs, you will notice that the ones at L5, S1 will not show up well. So if the patient is having difficulty or pain in that region, you ought to rotate the patient more like a 60 degree. But generally speaking, and in Merrill's, it states 45 degrees. But it also states that you rotate a patient up more if that patient has a low back pain. So off of the mid-sagittal plane, 30 to 60 degree rotation is what we need to be able to cut through the zygapophyseal joint. So moving on, landmarks that are very important for us to know. That at the xiphoid tip is roughly at T9, T10. It is a landmark, we should know. Lower costal angle, the margin of the rib. So if you feel on your lateral side, semi-lateral side, the ribs will come to a point. And at that point, that is at the level of L2, L3. This number, or all of these landmarks, will help you with other routines that we're going to be going over. Specifically for the lower costal margin, it is very important to know that it lies at L2, L3 due to the fact of our UGIs and how the stomach lies. But for lumbars, we know that if we find the lower margin, we're at about L2, L3, the disc space between. Going down further, the crest is always at L4, L5, always. It's a landmark that you should be able to regurgitate really quickly. Level L4, L5. As is at the sacrum 1 and 2. We all palpate the as is, but when you go horizontally across the body, we do not realize that it is at the level of L or S1, S2, sacrum 1 and sacrum 2. We all are pretty familiar that the symphysis pubis lies at the greater trochanter. So things to remember. Once again, xiphoid tip, T9, T10, lower costal margin is going to be at L2, L3, iliac crest, L4, 5, as is, sacrum 1 and 2, and the pubis, it lines up with the greater trochanter. Okay. We're all familiar with divergent beam, the divergent ray. And in all reality, due to the curvature of the lower lumbar, we should or could be doing it PA. That way, the divergent beam will actually be going through the inner disc space. We are looking for compression. We're looking for the buildup of a compression of the vertebrae, compression of the disc. We're looking for spurs developing on a lumbar vertebrae, narrowing of the disc, etc. When we do it AP, which 99.99% of the time, we shoot our AP lumbar. We shoot it with the patient supine on the table. But we should be cognizant. We should know that the divergent beam will cut through at an angle through the disc space, foreshortening the disc, making it so that it is closed off. Because of the curvature, secondary curvature of the lumbar spine. The only way that we can actually get away, maybe not get away, that we can modify it to flatten the lumbar. Anyone have an idea of what we should be doing? So most of the time, everyone just laid the patient on the table, supine.
Flex hips and knees.
Flex the knees, correct. That will straighten out the lumbar, making it more parallel to the table in the IR. That's what we should be doing every single time. Okay. So I just wanted to throw this one in here to be cognizant of the divergent beam, and also how in this PA or AP, the divergent beam will still affect your lateral, depending on which way the curve of the spine might be sagging. Whether the patient has wide hips or narrow hips, maybe their spine goes down at an angle, or maybe it's the opposite angle. We should be very cognizant of trying to get the spine parallel to the table for the best image. Whether that means placing a sponge underneath the waistline, that might help out. Or we angle in the direction of the curve. Something to be cognizant of. Okay. Essential projections for the L spine. Always do an AP, a lateral spot of L5S1, and we can do obliques and also a flexion extension. We'll talk a little bit about the lumbosacral region. The SI is going to be broken out a little bit later for us. Okay, starting with the AP. The AP is done on a 14x17, and that's going to be in a portrait. We do a 40-48 SID, centered at the crest. Suspend the respiration. Collimate side to side to include, making sure that you have included or are wide enough in your collimation to include the SI joint. flex the knees to flatten out the spine. And this is what we should see. Merrill states, center at the crest. What level is the crest at? 4 or 5, you are correct. What else do we center at the crest for? Abdomen, KUB, that's correct. And I'm only going to throw an argument out here. Note that this image, that if the patient was female, has no shielding. Note that the SI joint only comes down to this point. So the width looks good. But this whole region across here could have been shielded. In addition, for females, it doesn't hurt to put a shield across their breast also. But do note that when you think about your KUB, don't you normally include, depending on the height of the patient, body, habitus, etc., you can almost include T10, 11, and 12. So you could collimate top to bottom to maybe not have the ovaries, which lie in this region down here on bilateral, on the rim of the pelvis, to shield the ovaries from the primary beam and collimate top to bottom. Because really, the lumbar spine, as we know, only consists of 5 vertebrae, and they're wanting you to do it on a 14 by 17. And I'm making just an argument to you guys. Personally, a lumbar spine should never show, in my humble opinion, and this is not Merrill's, my humble opinion, should never show the pubic bone. Because we're not shooting. We're taking an image for the pubic bone to include the pubic bone. Lumbar spine is not in that region. Yet, because of the limitations on the sizes of DR plates that we have, what's the option? It's either a 14 by or a 10 by. And most places don't even have a 10 by. So I think it's important for you to collimate, not only side to side, but a little bit on the top to bottom. I will say and make an argument that you can get all 5 vertebrae in 12 inches. If centered correctly, you can get all 5 vertebrae. Before my time, they used to do oblique lumbars on a 10 by 12. You got to be right on your positioning. It's pretty tough. I did it on 11 by 14, so I had 14 inches to do it, but because it's only 14 inches long, the extra 3 inches compared to a 14 by 17, which is 17 inches long, those extra 3 inches and how I centered made it to where I never included the pubic bone. Even if I centered on the crest, I would have 1.5 inches above that. You have 1.5 inches above, 1.5 inches below when you collimate, or use a 14 by, or 11 by 14, excuse me. So just based upon the smaller cassette, we wouldn't include the ovaries. Something to think about. Your lumbar spine should never look like an abdomen. And I'm sure that you have seen some look like an abdomen. Andy, you had a comment?
So in Merrill's, it says for lumbar spine only, center above the crest, and then lumbar and sacrum
At the crest. Okay,
at the
I was
crest.
going to go there too.
So it's an order, say lumbar and sacrum?
Very good point. orders come over as either a lumbar or an LS spine. Doctors don't know the difference between an LS spine and an L spine in their ordering. They get, in my humble opinion, they just know a lumbar spine should include the sacrum, so they order an LS spine. Or even front office technologists, what have you, when we see lumbar, we know that we should be including the sacrum, LS spine. So it is true that for an LS spine that you should be centering at the crest. Otherwise, you should be 1.5 inches above the crest, centered at about L3 for the L spine. Even centering, and that's what's going to be part of my argument, even here's the crest. If I'm 1.5 inches above, I'm at L3. I can still collimate 14 inches top to bottom and not include. So if I actually do all my L spines or LS spines 1.5 inches above the crest, I'm always going to include the SI joint, which is a requirement. And the bottom of my image will never include the pubic bone. It's up to you. I just know personally, if I see that you guys are centering at the crest, I better see some type of shielding, gonadal shielding of the primary beam. It's up to you. Good question. Okay, I'm off my soapbox now. Lateral L spine demonstrates the intervertebral foraminas. This should ring a bell that the thoracic, we see the intervertebral foraminas on the lateral. Also, that on the oblique of the cervical is when we see the intervertebral foraminas. Know the pattern. Know that pattern, if you would. Now the question is, on a lateral, it doesn't matter if we do a left or right lateral. Merrill states that you could do a left or right. But how many times have you ever done a right lateral? Thank you, Andy. That's true. Unless the patient could only lie on their right side. And in that situation, I would turn the patient's head towards my right so that their back is towards me.
We did one in VR too.
Oh, you did? What happened?
No, remember the patient had his right side against the Bucky?
Yeah. So it happens. So 14 by 17, 40-inch SID, we're going to center at the crest. We're going to be at the crest at L4-5 in the mid-coronal plane. Now, for a LS spine, they say at the crest, and that we should actually be about 1.5 inches above the iliac crest. So find the crest, which this doesn't really make sense to me. Why would it be different than the AP? So you find the crest, go 1.5 inches above, now you're at L3. Along the mid-coronal plane, so you are collimating from side to side. Flex the knees, make sure that the lower back is perpendicular, but not only do you feel down in this region to make sure it is perpendicular, I span my hand across their shoulders to make sure their shoulders are perpendicular, as well as throughout the spinal column. If there's rotation in the shoulders, it will throw off the upper lumbar. If the hips are rotated, it's going to throw and rotate the lower lumbar, even though the shoulders might be perpendicular. You have to make sure both the shoulders and the lower back are perpendicular. Literally, I place my hands on the shoulders and hips if I need to rotate them, just trying to make sure that they don't over rotate, but they are rotating either their shoulders or hip. Note for this gentleman, he has a wider shoulder than hip. If they did not put a sponge at the crest of his pelvis, his spine would be going at an angle downward. It would naturally curve down. But because they built up his pelvis, crest, hip, what have you, they are now able to do a perpendicular beam. If you do not do that, you may have to put anywhere between a 5 to an 8 degree angle. Now, in this situation, I think it's backwards. I can see Drew kind of thinking that doesn't make sense.
Well, yeah, because it would be cephalic for the thoracic.
I would think so too. I agree with you. So, I think I have another picture here. One sec. I'll get to it. I would think that I'm going to do a 5 to 7 degree cephalic angle because it's wider at the shoulders, meaning that the spine is at an upward angle to the shoulder to match the curve of the spine. I agree. And in Merrill's, it does indicate that patients with a wider hip, you will have to go caudal. And in this situation, this guy's hips are narrower than his shoulders, so it should be cephalic. Okay, what is this vertebrae?
L2.
Body of L2. Next one.
Intervertebral?
Intervertebral would be back here. So what's between the body of L2 and L3?
The disc space or the disc?
Got it. Intervertebral disc space of L2, L3. Note that I did say L2, L3. Be very specific on the images that we do on the test. The next one. Intervertebral foramina of L3, 4. Going down here to this point, what is this bone?
Iliac crest.
You got it. Next one. Whoop. This would be the disc space between L5, S1. And then we come to the
Sacrum.
You got it, the sacrum. Now, I noticed that in lab, we were having a little bit of difficulty trying to figure out where T11 or T12 was for lateral. And it might be a little bit easier because now on a lumbar, we see the lower thoracic and all of the lumbar. So note, I've been talking about, or I said, do you see the rib coming off posteriorly? Note how this rib comes down. It's coming off of T12. Note that L1 doesn't have another bony, thin bone coming out posterior and inferiorly. Separate those two, and then I know this is 12. I follow it back up, that's 12. Note how these are not necessarily superimposed. So there's rotation in the upper spine. Yet, when we look at L1 through 5, note how, because of how they compensated, whether they angled or placed a sponge underneath the patient, where they centered at 3, 4, you can see directly through the spine or the disc space. And as we go higher, the divergent beams make them narrower. But because of how well it's positioned, we're pretty good on all of the disc space. But note on L5S1, we see the anterior portion, the separation in the disc, but as we go posteriorly, we don't. That is because of the divergent beam. So now, moving on to L5S1. We all have our own tricks of how to center for L5S1, correct? Some people will make a circle. Some people will put their third digit on the as is, wrap around the crest, make sure that when they bring their index finger around, that's where they're going to center. Some people will use two hands around the crest and go in the middle there. Are there any other tricks you guys have learned? No? Okay. The proper way per Merrill's is an 8x10. Column 8 down, you can even column 8 down smaller than that. You can column 8 to a 6x6 if you wanted to. 40-inch SID, you're going to be 2 inches posterior to the as is and 1.5 inches inferior to the iliac crest. So we're all able to find the crest and go 1.5 inches inferior to that. That's where the centering should be. It lines up with the 2 dimples that we have on our back side. The 2 dimples that we have in our lower back are where the sciatic nerves come out, is the junction of L5S1. There have been patients where I've had to run my hand down their back to try to find the dimples because I couldn't find any other landmarks. Whether they were thick around the waist, I couldn't palpate any of their structures. I went for the 2 dimples and making sure those 2 dimples are on top of each other in a lateral position so that I could either go straight or throw an angle on it to make sure that they superimposed each other, allowed me to get a better L5S1. So check that part out. Now, where we tend to be off or frustrated in our centering, whether we cup around the as is, what have you, is let's go back to the abdomen. How many times have you missed the pubic bone? Many of times, correct? And it's because that patient was heavier, correct? Hopefully. And because they're heavier, when we roll our hand up on top of the crest, we're not compensating for the fat pad that we're rolling on top of. So that fat could be 1/2 inch, it could be 2 inches, 3 inches. So now, because we roll our hand on top and we think, oh, that's where it's at, that means that we're centering higher up on the abdomen, meaning we always cut the pubic bone. Frustrating. Been there, still do that. It's frustrating. It's the same thing here. Because we're utilizing the crest, we have taken consideration. Not all patients are models. Doesn't matter if they're a model or a female model or a male model. We're not, you've learned and you've seen that all the body habituses are different with every patient you do. So these are the small little things we think about. Now, for all of the lumbar spine, we will suspend the respiration. So note on the picture, this one has a perpendicular beam because of the fact that you use the sponge. The lumbar spine is parallel to the IR, to where the dimples or they're superimposed on top of each other, that they could use a perpendicular beam. Otherwise, we may have to put anywhere between a 5 to 7 degree angle. And it depends on the girth of the patient. whether they have a very narrow shoulder up top on this left image, which causes the widening of the hip to arch the lumbar spine the opposite direction, or on the picture on the left, where it's actually curving downward. So there are times where if you don't build up the patient correctly, and this is the one you would have to build up from underneath, putting a sponge, a triangular sponge or something underneath to make the lumbar spine parallel to the IR. Literally, I don't think there's any problem with running your fingers along the spine to see which way it goes. Once they're positioned, do I need to build them up so that I can get a good intervertebral disc space between all of the joints of the spine? That's what you're shooting for. So for this one in particular on the L5S1, we can see the crest. We know which one is which. The magnified one is going to be the side away. Here's the side closest to. But do note how we see the anterior space between L5S1 here, and it starts to narrow out in the back. Compared to, look how narrow it is here. You can actually see an oval shape. See how the body tends to be of an oval shape? That is because it is not, and even when positioned correctly, the central ray on an L5S1 should be utilizing the straightest beam. It's because this patient was not positioned correctly that we're actually seeing an oval. What the oval is the depth of the body of the vertebrae. That's what we're seeing here, an oval. Because a primary beam is not, or the positioning of the patient is not correct, so it's slicing through the body of the vertebrae. Check them out. I mean, as you gain knowledge, you're going to critique and analyze your images even more, which I applaud. Every image can be improved. Question is, positioning, technique, centering, I don't know. It could be all of them for all I know. And it's happened to me. All of them were off. So note how wide the disc space is between 4 and 5. Note how you don't see the side down portion of the body here. It's flat. Yet over here, you do see part of the body. You do see some width of L5. And look how narrow the disc space is between 4 and 5 on the image on the right compared to the image on the left. You can drive a Mack truck through that one. I mean, that is good positioning, as well as what we're shooting for in the L5S1 region. I wish all my images looked that good. Okay, going on to the obliques. Obliques are becoming more and more obsolete, it seems to be. There are clinics out there that still do a 5-view lumbar spine, which would include the AP, lateral, spot, and both obliques. We always do the left and right oblique. Okay, so what we're looking for are the zygapophyseal joints. And as I stated earlier, we do look at both sides for comparison. Now, I've always said anything you do AP, you can do PA, correct? It's a matter of figuring it out. And it's true with the lumbar. But normally, we do all of our obliques AP because we start off with the patient supine on the table, and then we roll them right and left and then lateral. So they're done AP. Keep this in mind. I've always said images should be viewed anatomically, or they are to be viewed anatomically. This will help you in remembering which zygoapophyseal joints we're looking at in an AP oblique. So, as stated, the amount of rotation could be anywhere between 30 and 60 degrees, but for an oblique lumbar, we go 45 degrees. In an LPO or an RPO, we are looking at the zygoapophyseals that are closest to the IR. In an LPO or an RPO, we're looking at the ZAs, the downside ZA. And more importantly, the Scotty dog, as we go over the Scotty dog, will always point to the direction of the rotation. So if the patient is in an LPO, the face, the head, the nose will all be looking left. Always in an AP. So we're looking at the downside in a posterior oblique. But we can always do it PA. Then we're looking at the upside. And do note that this is off 45 degrees, but note how the facet is. We're not truly getting through it completely. Hence why I said the amount of rotation varies between 30 and 60 degrees. It depends. Depends on how curved that spine is. It could be, you know, it could be just their structure might be a little bit different or off. So when we're doing a PA oblique, which would mean that it would be an LAO or RAO, we're looking at the side away, the top side. But once again, I'm going to go back a slide. We do most of them AP, LPO, RPO. And in this situation, we're looking at the side closest to, and the Scotty dogs will face towards that side, the direction of the rotation. AP PA oblique, 14 by 17. 40-inch SID, 2 inches medial to the as is, and 1.5 inches above the iliac crest is where we're going to be centering. So that is similar to a lumbar, AP lumbar, 1.5 inches above the crest. The position rotation should be about 45 degrees, but when we're looking at the lower ZAs, you may have to go up to a 60-degree oblique rotation. Now, when we look at this image, whether I elongated or stretched it, the patient really doesn't look 45, do they? Well, yeah, I don't think so either. So I figure his as is about here, the crest is here. No, the crest is about there. Note where his umbilicus is. Doesn't the crest align with the umbilicus? Should. For most patients, they should be up here, 1.5 inches above. And 2 inches medial, here's the as is, 2 inches medial to the as is, along that line. So centering should be more about here, I would say. Here it is in a PA. Position of the patient would be an LAO. In this situation, we're 1.5 inches above the crest again, and we're going to go 2 inches medial to the lateral border of the patient. Collimate side to side and top to bottom. You can see where in this diagram that the rotation is exactly the same between the two, but the central ray is off. They're on a PA, they were on the side down, meaning that they were centered over here. where it should be centered above the spine. When you center above the spine, the divergent beam will include the spine. When you're centered on the downside, you run the risk of cutting off anatomy. So there have been a few times I've done a PA oblique. It's just because the patient presented that way and could not lie on their back. Whether there was a deep laceration, what have you, they would not go on their back. So flip it around and you can do a PA. Okay. So to start off with, if this is anatomical, what position is the patient?
Would it be an RPO?
You are correct. You are totally correct. Now, there's a few dead giveaways, and I haven't gone over the Scotty dog yet. But just to outline the Scotty dog, we have a nose, we have an eye, we have an ear, we have the neck here, we have the lower leg, and that means that the dog is looking this direction, correct? Towards this side. Knowing that it is a right, in an AP, it would be an RPO. In an RPO, which ZAs are we looking at, the right or left? I'll go back.
Right, the right.
The right side. So here's a patient, and they're in an AP, correct? They're rotated, so it's an LPO or RPO. We're looking at the downside, the closest side to it, which would be this one. So when we look at the image, we know they're going towards the right, which means that we're looking at the right ZAs. The ZA is between the ear and the lower leg of the Scotty dog. The other dead giveaway, if you cannot see any Scotty dogs, is the ala of the pelvis. Note how flat this one is over here. Note how this one comes up and down. This side is up. This side is down because it flattens it out, makes it flatter when you roll them. Take a look at that on your images. Meaning that the patient is in an RPO and we're looking at the right ZAs. They're rotated roughly at about a 45. We're actually seeing the ZA joints between, this is 12, 1, 1, 2, 12, 1, 1, 2, 2, 3, 3, 4, 4, 5 is there. And like I said, it's very hard to see the ZAs of the lower L5S1. That would be about there. Now it's closed off. We're not seeing through it. Whether it's because of the fact that the rotation of the pelvis wasn't quite enough, or that the shoulders and hips weren't aligned in the amount of rotation, but really it's because the pelvis needs a little bit more to see the L5S1, more rotation. Okay. If hung anatomically in an AP projection, what's the position?
LPO?
You got it. LPO. Note, this Scotty dog has a really small nose. We can see the ZAs, ZA there. This one's obliterated. I don't know what happened there. And the one below it, we don't see. But we know that they're looking towards the left side. So in an AP, it's going to be an LPO position. Note also how flat the ala of the pelvis is. Note how foreshortened the side up is. It's a dead giveaway. It's a double check. The dogs are looking towards the right, or excuse me, towards the left side, flat left pelvis or ala, shortened right. The patient's in an LPO. In an LPO, what ZAs are we looking at? Left side or right side?
Would it,
Go ahead, Brian. Joseph,
The left.
you are correct. You're looking at the left.
Real quick.
Yeah.
For the bottom Scotty dogs, if we rotated the patient, which way would we need to open up that joint?
You would have to rotate them more. You would have to rotate them more.
Okay, thank you.
Even in this position, I don't. Okay, there's L1, T12, 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. This patient has 6 lumbar vertebrae. That's what looks weird. There's no rib coming off this body. That, I think, is L1. We can see the rib, floating rib, floating rib. 1, 2, 3, 4, 5. 4, 5 should be at the crest. Correct? 1, 2, 3, 4, 5. And I think this is another vertebrae. So you know how I stated that some cervical vertebrae have 8? Here's a lumbar that has 6. That's a long lumbar.
Some people have an extra rib too, right?
They could. That's true. That's true. And being that I'm not a radiologist and I don't get paid the big bucks, I'm still going to say that there might be 6 vertebrae there. Okay. Know the Scotty dog. Know the Scotty dog. So they named it after because of the face and the shorter stature of the neck and the feet, what have you, and the ear and how it points up. So what we're looking at here is the superior articular facet for the ear coming down to the nose. This would be the transverse process. The round circle is because we rotated the vertebrae just enough that the pedicle is on line with the beam, making it round. This yellow portion would be that 2-word anatomy of the lumbar that I wanted you guys to remember.
Pars inter something.
Very good. Pars interarticularis. That is correct. That's the neck. Then we go down. This would be the inferior articular facet. And then there's a couple more back here that we'll talk about in just a bit. But do note, maybe it might be a stretch. Kind of looks like a Scotty dog, doesn't it? No? Yes, kind of. Maybe after a night of drinking, I don't know. So, note the direction of the head. In this image, actually in both of these images, if the patient was AP, what's the position of the patient?
RPO.
You got it. RPO. If it was PA, it would have to be the opposite, correct? Then it would be the LAO, correct. Hence why I've stated multiple times, whenever I'm looking at an image, I'm always imagining them in an AP projection. If I can figure out the AP, I can flip it over to do the PA, depending on the question that might be asked. So Okay, so number one, and this is supposed to be the Scotty dog with all the components. Number one, what is number one? This point here.
Superior articular process slash facet.
Yeah, process is great. Superior articular facet. Number two, now this is something we didn't get into in the tail portion. And it's an odd one. This is the superior articular process of the opposite side. Go figure. Superior articular process of the opposite side. What do you think three is? What is posterior to the pars?
Body.
Lamina.
Lamina. That would be the lamina. The lower leg. Well, if this is the superior, this would have to be the inferior articular process of the opposite side. Going forward to the anterior side, what is number five? Well, if this is the superior, this would be the inferior. You got it. 6. Go ahead, Mia. You did a good job on that one.
Pars interarticularis or whatever. Okay.
Good job. Pars interarticularis. That is correct. Number 7, the eye.
Pedicle.
Pedicle is correct. And the nose would be
Spinous process.
spinous would be on the back side. It's the transverse. Okay. Know the Scotty dog. Know the Scotty dog. And note, the Scotty dog is looking towards this side. So once again, if it's done AP, the patient would be in an RPO position. Okay. Just another one showing the position or the Scotty dog. This one has a small nose. Notice once again the pelvis. The ala on the right side is flat. This one's short. RPO. Dogs are looking towards this side, the right side. So we can see the nose, we can see the eye, the ear, pars, inferior. E would be the superior articular process. It's all there. So why it's so important when we do these positions or the obliques of the lumbar is that there are times and situations that the pars will break in that region, causing the spine to move forward, which is called spondylosis. And there's also another condition called spondylolisthesis. It's a slipping of the disc and everything going forward over the sacrum. Hence why we're looking in the region when we do our obliques to make sure there's not a fracture in that region. So, lateral lumbar, we can see 5, 4, 3, 2. See the crest, L5, S1, the disc space. There's a defect back here. You can see a small line going through. When they did the oblique of it, this one actually happens to have a little bit of no, it doesn't have contrast. It looks like it has contrast. When they looked at the pars region, here's the ear, here's the eye, the nose would come forward, the neck in this region, there is a defect There's an actual fracture in that region. And that would be through the pars interarticularis. Note that both the middle one and the one on the right, the position of the patient again. You can always see the flattening out of the pelvis. Whenever it's flat and the dogs are looking that direction, you have it nailed on the position. So we can actually see where the vertebrae of L5 has slipped forward over S1. Spondylolisthesis. It's a slipping of the disc of the vertebrae going over. What do you think of the centering on this one? A little bit high, huh? They're centered up here. Where on an L5S1, we should be looking at the joint space. But do note, once again, look how wide the joint space is.
Shouldn't they have rotated them more too? Because it's closing off that disc space of L5S1.
Well, look at the spinous process. Look how flat they are,
Yeah.
not foreshortened. So I think the patient was in a true lateral.
Okay.
The joint space of L4, L5 is so good that it would lead me to believe that the L5S1 joint space is actually really good too. It's just the condition of the patient.
I agree with you, Brian. I agree. I totally agree. Now, this is what they did to stabilize the lamina through the pedicle into the body of the vertebrae at an angle to keep it from sliding forward. There's an actual bar that keeps both of the vertebrae locked together. Okay, I'm going to go back to just a couple things I wanted to talk about. On an AP, where do you place your marker? Don't say on the patient.
IR in the book.
On the IR, okay, fair enough. This is just my rationale. All I care about is that you're marking the correct side, anatomical side of the patient. For a lumbar spine, you have to include the SI joint. Doesn't matter if it's a lumbosacral or a lumbar spine. You need to include both SIs. So here is the widest portion, correct? And always, because of the fact that I made mention, sometimes we see T10, 11, and 12, especially when we're using 17 inches of length. I place my marker up top. Now, if you've noticed, and you guys are becoming very consistent in your positioning along the mid-sagittal plane, that the spine is directly in the center of the plate. I take the midline of the center of the plate to the outside of the plate and divide that in half and place my marker. I don't care if it's in the ribs. I don't care if it's in the thoracic spine if I didn't adjust my patient or position my patient correctly. All I know is that being up top, I'm not going to be in the SI joint. That's for my AP. For the lateral, where do you place your mark on the lateral? Yes, Andy, I know, on the IR. Do you guys go high? Do you go low? Do you go posterior back here where it's always burned out? Yeah? Okay. Yes, I understand that every site's a little bit different. Some do not want it in any of the anatomy. I hear you. And in that situation, you kind of have to take advantage of the curvature and place it in the back. Now, oftentimes you will have a lead apron in the back side of the patient to collect the scatter radiation from overexposing the plate. And if your marker's here, because of the amount of scatter coming off of the spine, you're going to burn it out every single time. Has that happened? Yeah. So if you can't put it back here, you don't want to put it up here because you might run into a lumbar. You have two choices. You can either put it up here or you can place it down low. Is one better than the other?
Yes. Anterior low.
Anterior, high or low?
Low.
And why?
So you can use it to measure your L5 S1 joints, like to for the next image.
Well, that's a good rationale and it is valid. I place my marker low. I place my marker low because a lumbar spine is not complete, even on a limited lumbar, unless you do an L5S1, as Brian was saying. Even if my marker is in L5S1, does it really matter? No, not really, especially when my next image will be an L5S1. And note, if properly centered, I will see the body of 5, and normally I will see a lot of the body of 4. But because of the curvature of the sacrum, I always place my marker at a diagonal in the bottom corner. Make sense? Be consistent. Do the same thing over and over. Adjust your markers to where it's out of the anatomy, where you can actually see your marker. Now, when going to the oblique, where do you put your marker?
Same as AP.
Same as AP. Do I change my right and left when the patient's rotated left or right?
No, I use right the entire time.
Good job. Because you're still marking anatomically. That, I only use my right marker on my AP and my obliques. Always. There's no reason to put the left marker just because the patient's rotated left. I can tell if they're rotated in an LPO based upon the crest, based upon the direction of the Scotty dogs. But did I mark it anatomically every single time? One last thing. Can you tell me between the two images, which one's male and which one's female?
Would the left side be male because of the less curvature of the sacrum?
Anyone want to agree, disagree? You got a thumbs up from Andy Brown, Angel.
I was gonna.
We agree? Angel, you're correct. The image on the left is a male because of the angle of the sacrum. Note how a female goes posterior, angles back further to allow for a greater canal for birthing. Yep. Nice job, Angel, on that.